Hello everybody, continuing this series with question 81. I'm going to record this again because my microphone wasn't running. No problem, we'll go through this quicker now. In this question we have a 62-year-old man, fatigue, weight loss, the CBC shows 180,000 white blood cell counts, bone marrow shows hypercellular, granulocytic hyperplasia. Oh, look at that, 922. And so we know this is tyrosine kinase because of that CML, marked leukocytosis right there, splenomegaly. We have a left shift with that BCR fusion, and so you give them imatinib for the therapy. There are two types. There's receptor tyrosine kinase and non-receptor. Receptor tyrosine kinases are going to be like your insulin, your growth factors, your VEGFs. And then there's non-receptor tyrosine kinase, and that's affected by this condition with your BCR-ABL fusion of your chromosome 9 and 22. And yes, that's the basic of that one. All right, this next question, 83. Glyceric acid is seen in licorice. Basically, this woman has a supplement with licorice just to get high blood pressure and low potassium and low renin and aldosterone. So basically, it looks like she's got aldosterone, but she doesn't. Aldosterone is low in her body. And so which the enzyme is inhibited? Well, I was saying that 11 beta causes cortisol to turn into cortisone, which is the inactive form. And so we have apparent mineralocorticoid excess because of licorice, because it inhibits this and allows cortisol to activate these receptors, leading to hypertension, hypokalemia, and suppression of renin. So basically we have that cortisol build up because it can't be deactivated into cortisone. And that's what licorice can do to you. All right, maybe I should forget my microphone more often because we are cruising. For this question, we need to know a couple of key facts. 1, adolescents need calcium for bone growth. Number 2, if you substitute soda for milk, that will cause decreased calcium and increased phosphorus. If you have low calcium, then you'll have compensatory PTH because you're trying to correct that. So the PTH will go up, and then that will cause increased bone resorption. And so in the end, you'll get a lower peak bone mass. And that's why you got to drink milk. So if your milk intake declines, you have less calcium bioavailability. Bone mass accumulation continues into your 20s. And so if you have inadequate bone mineral accretion, then it'll cause problems later. So here we don't have, enough problems to cause rickets or something like that, but it will weaken the adult bones. And so the answer is decreased peak bone mineral density. All right, now there are a couple of conditions that it's not, and it's important to distinguish those. Like, for instance, why? It's not osteomalacia. That affects adults. Adolescent skeletons are still building. They're not remodeling, and so you wouldn't see osteomalacia. Primary hyperthyroidism would show high calcium, and so it's not primary hyperparathyroidism. Rickets requires significant vitamin D or calcium deficiency and physical signs like bowed legs, so it's not rickets. Now, here are some explanations. It's not osteopetrosis. It would cause dense but brittle bones. So yeah, if you just want to increase the risk of future fractures, then just swap out milk for soda. And that's question 84. Okay, so here we have a 10-month-old boy evaluated for frequent skin infections, hospitalized 3 weeks of age for omphalitis. His umbilical cord fell off at 4 weeks. Multiple episodes of perianal abscess with cellulitis, but rarely develops pus. This is classic leukocyte adhesion deficiency, and so the answer is going to be C. Anytime you see that delayed cord attachment, it's due to the defective beta-2 integrin, the CD18, which is essential for the neutrophil firm adhesion and migration to the infected tissues. And the reason you don't have that pus is because neutrophils would indicate pus, right? The absence suggests that they can't go to the site. Also, you have marked neutrophilia, which is leukocytosis. The cells are stuck in circulation. They can't leave. So you have a lot of neutrophils, but they just can't go anywhere, right? So CD18, this beta-2 integrin thing we were talking about, that is essential for LFA1 function, and it's needed for firm adhesion in the endothelium. Autosomal recessive inheritance is LAD integrin, and so you have impaired adhesion, and so the neutrophils can't exit the bloodstream. There's no infiltration into the affected tissues. The result is that you have a high neutrophil count, but there's no pus or local neutrophils. So the onset is, in infancy with recurrent bacterial infections. You have defective beta-2 integrins. White blood cell increases. No pus, and cultures are often positive, but the inflammation is muted. All right, folks, that's LAD. Now, important to know why the other answer choices they could give you are wrong. So they could give you something like a C3 deficiency, but that would show increased pyogenic inflections of the normal pus formation. The pus formation is a neutrophil thing. NADPH oxidase mutation could be another answer they give you, but that would cause defective killing, so you would still see the pus and the granulomas. It's not Bruton's tyrosine kinase. That's X-linked agamaglobulinemia. That'd be a low B cell thing, not a high neutrophil thing. And the infections would start after 6 months if that were the case. Here's an explanation with some trap answers and why they're wrong. Deficient opsonization would be seen in IgG or complement C3 deficiency. Impaired phagolysosome fusion, that's Chidia-Kagashi. Complement-mediated attack failure is that C5 to C9. Interferon gamma receptor dysfunction, would have disseminated mycobacterial infections. So you have a very high white blood cell count, there's no pus, and a belly button that does not fall off. That's leukocyte adhesion deficiency. It's all because the neutrophils can't stick to the blood vessel walls. Now on to Ascaris lumbricoides, 86. This one's pretty easy. You can see GI symptoms of obstruction, vomiting, distension, and respiratory signs of eosinophilic infiltration during the larva lung migration. So our practice question is, we have a 4-year-old boy. He has colicky, abdominal pain, nausea, and his mom remembers seeing white worms in his diaper, and that's the classic sign for C, Ascaris lumbricoides. All right, here's some trap answers by the wrong. Vermicularis would have perianal itching, not the large worms. Strongyloides would be an autoinfection, and eosinophilia would be seen. The worms are much tinier. The Trichuris is the rectal prolapse. And tinea solium would be undercooked pork and seizures. You'd have neurocystericosis. It's a flat tapeworm, not round. So this one you have to see recent travel or immigration from endemic regions like India or Latin America. So you have suspicion for a soil-transmitted helminth. And these eggs can be ingested through contaminated food or water, and they have to embryonate in soil before becoming infective. And the adult worms can migrate into the ducts, causing cholecystitis, pancreatitis. So you ingest them from the soil, the larvae invade the intestinal wall, travel to the liver, and then the lungs and the bloodstream. Then they mature in the lungs, and then they ascend to the bronchial tree, and then they're swallowed again. And it goes back into the intestine, and then they mature into massive adult worms, the world's most disgusting thing. What I will tell you for this is that the treatment is albendazole or mebendazole. So you see somebody from like Bangladesh vomiting, abdominal bloating, they pass a white worm in the stool and the diapers, then it's just going to be lumbricoides. All right, our next question here. 87, we have a 62-year-old man presenting with a 3-month history of progressive fatigue and some weight loss. He's got a 40-year pack history, vague abdominal discomfort. There's a mass at the head of the pancreas. What's the most modifiable risk? It's going to be smoking. Don't smoke, folks. Super modifiable cause. And this primarily forms through polycyclic aromatic hydrocarbons that increase the adenocarcinoma risk. And cigarette smoking is the #1 cause of cancer death. Lung cancer of all types, pancreatic adenocarcinoma, bladder cancer as well, esophageal, squamous cell carcinoma, cervical cancer, kidney, larynx, oral cavity cancers, all that stuff. Also, family history is important for cancer stuff. You guys remember the BRCA gene, your BRCA. That's breast, ovarian, prostate. Also, Lynch syndrome could have colon and endometrial and ovarian problems. And FAP, so the APC gene, that's colon cancer, 100% if it's untreated, by the way. APC totally will progress. Also, the leukemia is multiple tumors. So you have sarcoma, breast, brain, adrenal. There are also some other causes of cancer which are infective. These could be HPV 16-18. That's cervical, anal, penile, head, neck, squamous cell carcinoma. Also HBV, HCV. These can cause hepatocellular carcinoma. H. pylori is a super common one as well to be on the lookout for. H. pylori can cause gastric adenocarcinoma and Malt lymphoma. You know, Epstein's Barr virus as well can cause Burkitt's lymphoma and nasopharyngeal carcinoma. HHV8 is classically Kaposi's sarcoma. You can also have schistosoma, and that's the bladder cancer, squamous cell carcinoma, and cholangiocarcinoma. So look out for those infective causes as well. And another cause is the environment. So asbestos can cause mesothelioma and bronchiocarcinoma. Arsenic can cause lung and skin squamous cell carcinoma and angiosarcoma. Chloride is angiosarcoma of the liver. Benzene can cause AML. So aflatoxins can cause aspergillus. That can lead to hepatocellular carcinoma and lichen sclerosis, the vulva, squamous cell carcinoma. So usually it's going to be smoking, but whenever it's pointing to something else like genetics or an infectious etiology, it's going to be something else. But indeed here, our correct answer is smoking, definitely for pancreatic cancer. All right, next, 88. A 9-year-old girl is evaluated for persistent neck pain following a fall. She's got congenital fusion of the C1 and partial fusion of C2 and 3. Which structure is under increased stress? Atlantoaxial joint. So the fusion of 1 and 2 to C3 immobilizes them. And so C1, 2 is the only mobile segment. And so that takes all of the flexion, causing that overload. Here the trap answer, cervical sympathetic. It's not involved in mechanical stress. It's related to Horner syndrome though. C5, 6 is too far caudal, vertebral, courses through the transverse foramina. It's not affected there. And temporomandibular joint is involved in jaw movement. So when the vertebrae, whether it's from, something congenital like your birth or maybe surgery, something else has to move a bit more to compensate. And so here the occiput is fused to C1 and C2 is fused to C3. So that leaves C1 to 2, the atlantoaxial joint, as the only mobile piece in that region. And so that's why it's going to cause extra stress there. This is associated with Klippel-Feil syndrome, is a short neck, low hairline, limited neck movement due to the cervical vertebral fusion. All right, and this one's going to be a super simple question. You start school in August, and so AUG is actually the start codon. So if you're trying to stop the starting where the tRNA interacts with the mRNA, you should stop at the AUG. And that's the tag for methionine, and that's all you need to know. All right, next for 90, what we need to know is most cardiac arrests in public are shockable rhythms. VFib, VTAC, out of hospital arrest survival is time dependent. And so AEDs improve bystander response time. So if you ingest ROI, just go ahead and put a bunch of AEDs all around. Basically using AEDs within minutes helps to stop ventricular fibrillation. It's the most common cause of sudden cardiac death in public settings. The other answers aren't right because aortic dissection is rare in public and you can't correct it with defib. Myocardial infarction doesn't treat it, only treats the arrhythmia. Pulmonary embolism, the shock won't reverse the clot. Asystole is not shockable. And every single minute that you go without defib during cardiac arrest, your survival drops by 10%. So that means a minute is life or death. That's why you see AEDs everywhere. You got to shock those guys. In our next question, we have a 40-year-old woman presenting with severe flank pain and hematuria. She was treated 3 weeks ago with a UTI caused by Klebsiella pneumonia. Urine analysis shows a pH of 8.1. Microscopy shows rectangular coffin lid. That coffin lid should tell you it's a Struvite stone. Game over. This is alkaline, so it's a staghorn stone. You can see that by the coffin lid stuff. You have to memorize these guys. There's no other way around it. On test day, they'll give you some other answer choices like cysteine. That's in cystinuria. Those are hexagonal though. Calcium oxalate, most common, but it forms in acidic environments. That's not calcium oxalate. Uric acid, that forms acidic urine. And it's radiolucent and lacks infection associations. Calcium phosphate is seen in distal RTA, not the setting of UTIs. So yeah, these staghorn guys, they're giant renal colliculi that mold into the kidney's collecting system just like a cast does. It's the Struvites. Easy. The only other thing to know is that women are at higher risk because they have a shorter urethra and increased infection rates. And Proteus mirabilis infects the urinary tract as it produces that urease. Urease converts urea to ammonia. So think about that. If you have ammonia and CO2, that's going to alkalinize the urine, and you have a high urinary pH promotes the precipitation of certain stones, which are magnesium, ammonium, and they look like that coffin lid shape. So that's exactly the reason why. Okay, in our next question, we have a 10-month-old boy who has persistent diarrhea, poor weight gain, and swelling of the face and legs. Stool is bulky, foul-smelling, oily. Labs show serum albumin and duodenal aspirate high in trypsinogen and chymotrypsinogen. Which of the following is deficient? Answer is enteropeptidase. Why? That's the gatekeeper enzyme. It activates trypsinogen into trypsin, and that's enteropeptidase. It's not lipase, that's a fat digestion enzyme, not amylase that breaks down starch. Chymotrypsin is downstream. That's inactive because of the trypsin deficiency. And carboxypeptidase also requires trypsin for activation. So you have no trypsin, there's no digestion. This is an enteropeptidase deficiency in the infants. You can see failure to thrive, chronic diarrhea, hypoalbuminemia. This is just malabsorption, protein loss, and edema. If you have a mutation in your enteropeptidase, this is going to be probably autosomal recessive, super rare. Then this whole zymogen into trypsin thing is not working, and trypsin does a whole lot of stuff. Also, this is a protein losing enteropathy, so you lose things through edema because of hypoalbuminemia. You have low protein in the blood due to undigested proteins in the guts. And you can see this in infants in the first year of life, diarrhea, swelling. Basically, the pancreas secretes trypsinogen, and that's the inactive form. And then enteropeptidase in the duodenal brush border converts trypsinogen into trypsin. So that's the whole job here. That's like your thing that you do, right? We got our pancreas secreting trypsinogen, but the enteropeptidase can't do anything with it. And so trypsin is important because it activates other proenzymes like chymotrypsin, preolactase, and all these other things like procarboxypeptidase. And without enteropeptidase, no activation, you get malabsorption, and that causes osmotic diarrhea, failure to gain weight, edema from protein loss. And the treatment is you have to have oral enteropeptidase replacement. It's the only way around this. It's like, what good is the pancreas' secretion of trypsinogen if you don't have enteropeptidase to break it down? All right, we got a lot to talk about for this one. So if somebody's got dysphagia to solids and liquids, then it might be a motility disorder, not an obstruction. And you might see shiny, tight skin on the hands and the face. That's Raynaud's syndrome. And so with that shiny, tight skin, we're thinking about systemic sclerosis of the Crest variant. And on manometry, you'd see decreased peristalsis and a decreased lower esophageal sphincter tone. And this is due to the fibrosis replacing the smooth muscle in the distal esophagus. This is associated with anti-centromere antibodies with Crest syndrome. You can also see pulmonary arterial hypertension. It's a common complication in Crest due to your vascular remodeling. Calcinosis as well, angiectasias, and sclerodactyly. And there's an increased risk for Barrett's esophagus, from the chronic acid reflux due to that lower esophageal incompetence. And I think the pathophys is very important here. So here we have autoimmune inflammation. You get fibrosis of the esophageal smooth muscle. Fibrosis. That leads to a loss of normal peristalsis in the distal 2/3 of the esophagus. And again, this is all Crest syndrome. It's an autoimmune condition causing the fibrosis here, causing the lower 2/3 to be problematic. And so your low esophageal sphincter loses its tone, and that causes gastric reflux. And then you get dysphagia that arises from both weak propulsion and often the open sphincter as well. So you'll see decreased peristalsis and a decreased LES tone, and that causes the skin to be all tight and shiny on the hands. You see sclerodactyly. So our answer is going to be decreased peristalsis and decreased tone. You wouldn't have increased tone. There's one other thing. There's Raynaud syndrome. That's the tricolor change with the cold. The labs would show a positive ANA anti-centromere or anti-SCL70, which would mean it's already diffused at that point. And also you could see Barrett's esophagus, and as we all know, Barrett's esophagus is directly going to lead to adenocarcinoma. So on the question send, this can present in very different ways. But they might say they have Raynaud's by saying they have a cold-induced finger change colors, shiny, tight skin on the face and hands. They could also say they've had trouble swallowing solids and liquids. This leads you to think they probably have Crest syndrome. And they'll try to get you. They'll try to get you with some different answers, like achalasia. Why is it not that answer, right? Achalasia has a lower esophageal tone that's increased, not decreased. And dysphagia is mostly just to liquids with the bird beak sign for achalasia. So that one's is achalasia has that increase there. GERD is where the LES may be weak, but the peristalsis is intact. And there's no systemic signs like Raynaud's or skin changes. Zenker's diverticulum is more common in elderly men, causing a regurgitation of undigested food. And eosinophilic esophagitis is typical in young men with food allergies, presents with solid dysphagia only and eosinophilic on biopsy. So when somebody can't swallow their liquids and their foods, you have to think about what moves through the esophagus. So there's a muscular tube that is slowly turning into scar tissue. And that's what happens in Crest syndrome. It's a limited form of systemic sclerosis, autoimmunity that leads to fibrosis of the esophageal wall. And this especially affects the distal 2/3 and the lower esophageal sphincter. So you don't get any of that tone, and so the food just kind of sits there, or it could, even have reflux up to the esophagus. And that's why you get dysphagia and heartburn. And so you see decreased peristalsis and decreased LES pressure. And they also have the tight, shiny skin, sclerodactyly. And sclerodactyly is just the thickening and tightening of the skin and the fingers. It looks like a claw appearance and has limited mobility. It's a sclerodoma thing. Yeah, so that is going to be Crest syndrome. All right, for this next one, we got our little spinal cord drawn here. So these guys right here are your dorsal columns. These guys can transmit the pressure, vibration, proprioception, and also some fine touch. This guy right here would be your lateral corticospinal tract, and this is on the right side, carries the nerves on the right side of the body, and the left corticospinal tract is over here. That'll have the voluntary movements on the left side of the body. But of course, they originate on the opposite side of the other motor cortex in the brain. And then right here and here, these guys are the anterior corticospinal tract. They decussate through the anterior spinal commissure at the synapse of the ventral horn. What we are looking for, though, is the spinothalamic tract. We get our pain and temperature here. In our question, we have a 29-year-old man being stabbed on the right side of his neck, complete loss of pain and temperature and sensation on the left side. So the vision and proprioception is intact, so it's nothing in the back end there, not the dorsal columns. Which region is most likely affected? It's the right lateral spinothalamic pain and temperature. That's how you know it's that track. And then you just have to identify it on the diagram, which I've drawn for you. All right, next we're going to talk about a very important pathophysiology here. You got some cirrhosis, and that cirrhosis is going to block hepatic sinusoidal flow. That causes an increase in the portal venous pressure. And then you get some backflow into the left gastric vein, and that dilates your esophageal veins. And then the submucosa in the lower esophagus will bulge, and that's called esophageal varices. And so in this condition, you can see the vomiting of the red blood, jaundice, spider angiomata, ascites, dilated varices. Prophylaxis is given with propranolol. Now let's do a practice question. A 58-year-old man, chronic alcohol use, presents to you after vomiting blood, pale, tachycardic, abdominal distension with a shifting dullness. He's got scleral icterus and spider angiomata, so cirrhosis and large tortuous veins in the lower third of the esophagus. Bleeding vessels receive blood from which? Answer is the left gastric vein. All right, so we have a liver with cirrhosis, if you can see in this diagram here. And so you get fibrotic nodules that block the flow. And so the blood can't flow smoothly, and that increases the portal vein pressure. And that will back up in the portal tributaries, especially the left gastric vein. So now we got that back up here, and then we have to deal with varices, and then they can rupture and causes massive GI bleeds. And that can cause the hematemesis and that should always make you think of variceal bleeding. You'll see the tortuous blue columns under the esophageal mucosa. You can see thrombocytopenia, elevated bilirubin, and low albumin, and you prevent it with propranolol. Okay, it's not inferior mesenteric. That drains the distal colon. Not short gastric, drains into the splenic vein. Right gastroepiploic, greater curvature of the stomach, and hepatic vein drains from the liver into the IVC. So there you go. All right, for our next question here, this is a folic acid deficiency. You can see the hypersegmented neutrophils. This is seen in chronic alcohol use because alcohol impairs folate absorption in the jejunum. Low folate intake plus increased requirements for the turnover, so you need more folate for DNA synthesis. And alcohol inhibits that. Folate is needed for a DTMP for a DUMP. The deficiency halts DNA replication, and so you get megaloblastic anemia. And so you have large immature red blood cells that look like this. This is seen in MCVs greater than 100, hypersegmented neutrophils, pancytopenia. Our practice question, 61-year-old man, history of alcohol abuse, which of the following is deficient? The answer is folate. Iron would be microcytic, is Wernicke-Korsakoff, but it doesn't cause macro. Then pyridoxine is deficiency in sideroblastic, and that's microcytic. And to show you how common, it's 50% of people with alcohol use disorder have folate deficiencies. And that's what you need for DNA synthesis. And without it, your bone marrow can't make healthy cells. And so you have megaloblastic anemia, large immature red cells that don't function very well, and often pancytopenia as well. All right, now on this next question, here is the uterine artery. So you can undergo a procedure that's used to shrink the fibroids and stop vaginal bleeding. So the uterine artery is a branch of the internal iliac artery. So you can see that here. Right there, that's the flow, internal iliac. And the uterine artery courses anterior to the ureter. You've probably heard water under the bridge. Helps you avoid it in procedures. And there's uterine and ovarian arteries that anastomose and it can offer collateral blood flow. But the way you enter the femoral artery is you know that it's a continuation of the external iliac artery. So the catheter will ascend in the common iliac and then it goes to the internal iliac. And then the uterine artery branches off anterior division into the internal iliac artery, and embolic agents are delivered there to treat the fibroids and postpartum hemorrhaging. So there's our question. So the route is the femoral to the external iliac to the common iliac to the internal iliac to the uterine. It's also worth noting that leiomyomas are estrogen-sensitive uterine tumors that are blood-hungry. So to access it, we just have to know how these artery systems are set up: femoral, external, internal, uterine. And as long as you know that the uterine artery is a direct branch of the internal iliac, that'll help you narrow things down. And the femoral artery is a continuation of the external iliac. So the catheter would be advanced through retrograde through the external iliac and then internal and then uterine. That's how you get there super quickly and do the embolization surgery. All right, next, which type of shock is this? You get cool, pale extremities, JVD and rails. It's low output states, so it's probably cardiogenic. Associations would be myocardial infarction, elevated left side because it's left side backup, increased SVR because there's vasoconstriction to maintain the pressure. Here the pathophys is you have a cardiogenic pump failure. Blood will back up into the pulmonary circulation, causing pulmonary edema. And you also get problems because you're underperfused. That's what causes you to be cold. You have vasoconstriction because the baroreceptor reflex is like, got to keep things going. And you can have hypoperfusion. So here's our man, our guy, 60-year-old, confusion, low output of urine. Look at that low BP, bilateral crackles, distended neck veins, cold extremities. What's most likely here? Probably going to be backed up. So decreased cardiac output is surely going to be the case, but you're going to have increased SVR, so you can compensate there, and not normal. It'd be increased pulmonary capillary wedge pressure because it's backed up on the left side of the heart, and the failing left ventricle just can't push forward. Okay, here are the wrong answers. Distributive shock has a low SVR. Neurogenic, both would be low, but this would stay normal. So yeah, cardiogenic shock has the highest in-hospital mortality of all the shock types because the heart just can't keep up. You get a big, like bad valve or massive heart attack or end-stage heart failure, something like that. It's really serious. Okay, first of all, what causes chronic pancreatitis for our next question? And it is alcohol use disorder is the number one cause of chronic pancreatitis because ethanol causes direct acinar toxicity. In fat-soluble vitamin deficiency, a lipase needed to emulsify fat for absorption, impaired with pancreatic insufficiency. You can also have islet cell loss that causes secondary diabetes. Here's the pathophys, recurrent inflammation, pancreatic enzyme output. The fat stays in the stool. Malabsorption can occur. Steatorrhea has the foul floating oily stools. Fecal elastase is a marker of that exocrine insufficiency and can cause ADEC. So there's a 60-year-old man with a 15-year history of alcohol use disorder with weight loss, abdominal discomfort, foul smelling, greasy stools. He has normal appetite, difficult to flush. Labs show mild anemia and low serum levels of A and D. What's the most appropriate step? The answer is oral pancreatic enzyme replacement, fat-soluble replacement. So this is pancreatic exocrine insufficiency from chronic pancreatitis due to the long-standing alcohol use. Steatorrhea, weight loss, fat-soluble vitamin deficiencies, lipase-dependent digestion. Now, steatorrhea is undigested fat in the stool, and chronic pancreatitis makes sense there because you get like a bunch of inflammation that leads to exocrine insufficiency, so you can't digest that fat. That's why you had the fat content in the stools, is due to the loss of pancreatic lipase. You could also see other associations with this stuff, like it could be like a CFTR mutation with cystic fibrosis. Alcohol use is the number one cause, though, of chronic pancreatitis in adults, and the ADAC deficiency is due to the impaired micelle formation and fat digestion, and diabetes can lead to your insulin loss if those things are damaged as well. So you have chronic injury, either alcohol, genetics, trauma, repeated inflammation. This causes progressive fibrosis and atrophy of the pancreas. So you have the loss of those acinar cells, decreased secretion of lipase, amylase, protease, and malabsorption of dietary fats. The fat-soluble vitamins A, D, E, K can't be absorbed. You get night blindness, osteomalacia, neuropathy, bleeding, all that good stuff. And the treatment is pancreatic enzyme replacement and also vitamins. The fat-soluble vitamins, you just got to replace those guys. It's not anything else. Like iron is water-soluble, so it's not that. You don't decrease your fat. That would risk malnutrition. So if the stool floats and stinks, then it's going to be the pancreas that's like, guys, I'm dead. Chronic pancreatitis. It's inflammation. You scar the pancreas until it can't make the enzymes like lipase anymore, and your fats just don't get digested. All right, 99. So our pathophys here is we have methionine, homocysteine can build up, and you get marfanoid thrombosis and all this stuff. So we have a 12-year-old boy, recurrent leg pain, tall, thin, long legs, prior DVT, elevated plasma homocysteine and methionine, and low cysteine. Which enzyme's deficient? Cystathionine beta synthase. This person has homocysteinuria. So instead of just converting homocysteine to cystathione, homocysteine just builds up in the blood. And so methionine gets turned into homocysteine. And normally CBS helps homocysteine become cystathionine to cysteine. But if CBS is broken, homocysteine just piles up and the cysteine levels go down and homocysteine goes up. And so you get lens dislocation, you have downward inframedial dislocation, tall, thin bodies like Marfan's, mental disabilities, blood clots, DVTs, high methionine, and homocysteine. And homocysteine should turn into cysteine. But in this kid, that last step right here, this is broken. And what's broken? It's an enzyme that's called cystathione beta synthase, CBS. It's missing. It's not working. So to homocysteine, that works. Check. This part doesn't. And so what happens if we have homocysteine buildup? Well, in the brain, we get intellectual disabilities. In the eyes, the lenses fall out of place. In the bones, you become tall and skinny. And in the blood, you get a high risk of clots. And so cysteine is low. And so cysteine pathway is messed up as well. It's super bad. So not only do we have tons of homocysteine, we also have low cysteine. So it's too much of this and too little of that, and that causes all sorts of problems. And so how we fix this is we give vitamin B6. That helps the enzyme work a little bit better. And also folate and B12 shifts the homocysteine that you have in excess of into another path. Folate and B12 is like, hey, let's make this homocysteine useful after all. And there's less methionine in the diet, more cysteine. So that is the function. That's how this works. Okay, and for our last question here, we have a guy who has sudden chest pain, dyspnea, and syncope. It's going to be a pulmonary embolism. He has JVD, clear lungs, hypotension. He's got increased pH, decreased PCO2, decreased PO, acute respiratory alkalosis due to hyperventilation. And also we have enlarged right ventricle cavity due to the sudden increase in pressure load. There's hypercoagulability that's inherited or acquired. It could be factor 5 lead-in, OCPs, pregnancy, malignancy, all sorts of things that can cause your hypercoagulable states. The most common source of a pulmonary embolism is femoral, popliteal, and then the calf. An acute cor pulmonale is the right heart strain from sudden increase of pulmonary vascular resistance. So the pulmonary embolism obstructs the pulmonary artery, and that causes an afterload increase. Right ventricle dilates acutely, there's no time for hypertrophy, and the left ventricle preload decreases because we ain't getting through there. Hypoxemia happens because of that mismatch, and get compensatory hyperventilation. And so our practice question, we have a 29-year-old woman with acute onset shortness of breath. What finding is most likely? It's right ventricular dilation. And so the key signs here is hypotension, but also the lungs are clear as well. And you have to know that this would cause dilation of the right ventricle. Okay, that's the last question. That's 100. So we've done 100 of these questions that I believe are important for you to know by the time that you finish MBME 27. If you want to see the rest, then please like and subscribe. It really helps out the channel. We'll be improving these videos each day, and I think I might start another one here. There are only 2 more sections of topics, but please, it'd be amazing if you could leave a comment or just like or subscribe. Tell me how I can improve these videos. I'm always trying to do better and better. Also, you may have seen these lights, but I've got them programmed to just change colors whenever somebody subscribes. So if you want to see that happen, just some random point of the day, then just be sure to do one of these 3 things. The sub would be great, and we'll see you guys in the next video.